let's talk about respiratory failure, an approach for interns. We're going to spend the first part focusing on different options at your disposal to provide oxygen support for your patients, and then spend more time using illness scripts and figuring out why people are having respiratory failure in the second part of our talk. So kind of defining symptoms, and for me and throughout this talk, I hope that I convey to you that who requires oxygen is important, but people who have symptoms are just as important to me, and the inability to resolve symptoms is concerning. May also be something that means that you haven't figured out what's wrong and maybe what drives them to get worse. So symptoms matter to me a lot, but you could have shortness of breath, air hunger, be breathing 30 to 40 times a minute, or coughing your brains out, coughing up phlegm. You could have all these symptoms and a variety of pulmonary processes undergoing and still not require oxygen. It's kind of, there's a lot of factors that go into who's going to actually become hypoxic, but, I wouldn't write somebody off as not sick just because they don't need oxygen. In fact, there are plenty of people who are as sick as they can get and won't need a lot of oxygen until their heart stops or they develop hemodynamic collapse for another reason. So pure hypoxic respiratory failure would mean that you need oxygen to keep an O2 sat greater than 90%, whereas if you have blood gas results and your CO2 is elevated and your pH is low, that would be hypercarbic respiratory failure. You can certainly have both as well. Determining if your patient is stable or unstable is the key and name of the game to how an intern should be evaluating respiratory failure. So if you go to see somebody, here are some signs that they're unstable. If somebody is breathing greater than 30 times a minute, that would be concerning to me. Breathing in the 20s, I think, is kind of like having a sinus tachycardia between 100 and 115. That's sort of your safe space where I don't think you're going to burn out the engines. When you start breathing close to 40 times a minute, that's not a situation that's going to sustain itself for very long. That should be concerning you a lot. An immediate indication of respiratory distress and unstable status is accessory muscle use, kind of just gasping for air. Sometimes patients will be sitting up, leaning forward, tripoding in the bed. That's another sign of distress. If you look closely at their neck, you can see the muscles sort of go down as they're breathing, and you see that effort in their chest. Those are all signs of accessory muscle use and distress. That would be an automatic reason to intervene immediately with something, and often somebody who needs ICU level of care. And lastly, even if somebody doesn't feel too bad, oxygen saturations dropping below 80 should hint you into this is a developing urgent emergent situation, and you got to make that better right now. And in general, I think you should be at bedside. That's the key point here. You should be at bedside working with nurses and RTs to make sure that you're finding solutions, working up, and not leaving the situation until someone is comfortable. That's a sign that things are getting better. And their oxygen saturations are greater than 90, whether that's on room air or on a little bit of oxygen. So until you've achieved those things, you should be at bedside and brainstorming and working with your team to figure out how to best care for this patient. The reason why O2 sats are a big deal and why you should take them seriously and be concerned is when someone's SpO2 gets down into the 80s, you might be getting right about here on your oxygen hemoglobin to saturation curve, which means once someone goes from 88 downward, they go down very quickly. In fact, that's when they start to really skyrocket downward. So within 10 seconds, you could go from 88% if you're going down to complete anoxia or profound hypoxia, and just a second or two around the corner from there is a possible cardiac arrest, PEA arrest, and that's not good, and that won't take long to happen. So that is why you and your nurses should not take hypoxia lightly. You should make it better, and you can make it better often with the tools you have at bedside to start. However, in the most profound or severe cases, and in cases where it's not a simple oxygen problem, that's why there's a code blue button behind the bed. Now, to understand oxygen support, something that I really didn't understand before starting, my intern year, and learned throughout my intern year, is how we determine how much oxygen we're giving, what it means, and what factors really determine the degree of oxygen support you're giving. So, for example, really how much oxygen you're giving people depend on these two factors: your fraction inspired oxygen and your PEEP, positive end expiratory pressure. And I use PEEP probably a little bit too globally in doing this talk. So the pressure from a CPAP and the pressure from a BiPAP, to some extent, in my view, are positive pressure. They're PEEP, right? And they're driving pressure to help open the airways, keep those airways open, and facilitate opening alveoli and exchanging oxygen. Whereas the amount of oxygen you're giving, the fraction of oxygen you're giving, is really something that just tells you, crank it up, how much oxygen am I on? Room air is 22% FiO2. FiO2 goes from, and that's 0.22. FiO2 of 0.2 is room air. FiO2 goes all the way up to 1.0. All right, so if you're on 100% oxygen, FiO2 100%, that's 1.0 FiO2 if you're doing it the right way, okay? And we'll get into a minute which modes of oxygen can deliver how much oxygen. That's the next slide. So basically, when you look at someone's settings, look at what they're wearing for oxygen, and you look behind the bed or look at the machine to see what percent the FiO2 is, that should tell you something. Anybody who needs more than 40% FiO2 to maintain stability is pretty sick. They require a lot of oxygen. Now, let's say you had somebody, one patient on your step-down unit who's on 40% FiO2, but the person next door is on 80% FiO2. That's somebody who you should be every day, if someone's on that much oxygen. That is such a high amount of oxygen that most of those patients, and in many hospitals, that patient should be in an ICU. That's such a high amount of oxygen, you don't have much more room to go. So that's a pretty severe and critical number there, right? Now, the amount of PEEP someone is getting also matters a lot. So for example, if you really need a CPAP just to be comfortable, and on top of that, you need greater than 40% FiO2 on that CPAP with 5 or 10 of PEEP just to be comfortable, that's also a lot of pressure. And that's not a lot different than what you're giving somebody who's on a mechanical ventilator. The difference is that they're sedated and you're kind of doing it for them. So this is how I want you to think about, is my patient more sick or less sick? And as long as they're comfortable here and their O2 sats are okay, you don't have to be actively strategizing and kind of feeling anxious at the same time. If you know which patients you don't have much wiggle room with, or who are highest risk of getting sicker, that's what I'm trying to show you with this slide. Every single hospital room has these forms of oxygen support. A nasal cannula, that's the first thing the nurses will put on a patient if their O2 sats go down. And what you must know is that the nasal cannula is a very small tube. That tube will only let a max of 6 liters per minute of oxygen go through it. And so 6 liters of nasal cannula is the max, and that correlates to 40% FiO2. That's as much as they can give you. So if someone's O2 sat is less than 90 on that, then you need more. And that may happen when you're not in the room, and if that's the case, that's when your nurses will throw on a face mask. The most typical face mask available in the room is a non-rebreather. It connects to the oxygen behind the bed, the same thing the nasal cannula is attached to. And just so you know, that thing behind the bed where the oxygen, little thingy duty that tells you 1 liter to 14 liters. If you're on nasal cannula, here's 6. You may see it turned up past 6 behind the bed, but it's not going to be giving more than 6. If you put this mask on, the non-rebreather, they often will crank it up closer to the max, and then that amount of oxygen is actually being delivered. So the non-rebreather can deliver a higher volume of oxygen, and it can give a 100% FiO2 delivery. And this is what you would normally see nurses doing when they're trying to get you to bedside, someone's unstable, their O2 sats are dropping. This is a way to kind of get things stable until you can get there, make some more decisions, and stabilize things further. All right, and anybody who needs more than 5 liters nasal cannula, I would say should be in the step-down unit. High flow nasal cannula. This is not a very old technology. It's pretty new. I don't know that I heard about it much before residency. It's very, very cool. Offers you a lot of flexibility. So note back here, this mask will not let your patient eat, drink. It's a pretty limited form of support. The high flow nasal cannula is awesome, but it's a separate machine. So that big sucker's got to be wheeled into any room where you're doing it. It functions based off liquid oxygen and humidifies the air, and it can deliver up to 100% oxygen. And it's typically set with a high liter per minute flow. So you're giving a high amount of flow and a high amount of oxygen. And it's nice as well because it offers you a little bit of PEEP. And as you'll learn in residency is that if somebody has anything beyond a simple process causing hypoxia, PEEP is going to make them feel better. Oftentimes you might have people with good O2 sats on a given amount of nasal cannula or a mask, but without a little bit of PEEP, they still have air hunger or dyspnea. So the PEEP here with high flow is another tool or function of it that helps to make your patients a bit more comfortable and stable. But you see it's just a bigger pronged machine, nasal cannula tube, so it just takes a bigger volume of air and lets it go through. You have to be in a step down or an ICU to use this, but certainly in the medical ICU, you'll see these used for people with a profound pneumonia, people who they're trying to avoid intubation with. If someone has a primary oxygen problem, that's the biggest issue they have, then this can be the answer to their problems. It will not help somebody who is retaining CO2 and dropping their pH. So you must know that that's a limitation, and it will not necessarily help you. There's lots of people that in a panic, somebody put on BiPAP, where at the same time, you could probably consider a high flow nasal cannula if they're not developing acidosis. So choosing for somebody who you put in the step-down unit who needs more than nasal cannula, you have a few options, which we just talked about. You could do the face mask, called the non-rebreather. There's also a thing called a venti mask. The non-rebreather is fairly archaic technology. It's the kind of thing you would have in the back of an EMS truck. It's just kind of simple. Venti mask is usually adjusted by an RT with different settings, and the FiO2 for a venti mask can be, titrated to different levels and can be a way to wean people off oxygen. But at any rate, whether it's a non-rebreather or the venti mask option, it's a small plastic face mask that sits over the face and just blows air over it. It doesn't offer any significant PEEP. It's just a passive form of oxygen delivery. And so that's just something to be aware of. And again, you can't eat, you can't drink, and for that reason, it's something that if your patients are not going to get better in 1 hour, it's fairly limited. High flow is the optimal choice that I would say we use in residency for anybody who is in a pickle that's going to need this much oxygen for more than a few hours. And it's mostly very well tolerated. Okay, not a lot of downsides other than it doesn't fix hypercarbia. Some patients will not like the humidity from the high flow. They'll complain about it. But usually working with the RT, they can find a way to tolerate it. Sometimes if you're weaning down somebody off of high flow and you're trying to reduce their oxygen requirement to see if you can put them on regular nasal cannula, you can switch them to something called an oxidizer, which is also a nasal cannula, but it's just thicker and bigger so more O2 can flow through it. The nice thing about an oxidizer is that it's not a separate machine. The oxidizer can be attached to the oxygen supply in every room behind the bed. And for that reason as well, an oxidizer could be used to send somebody home with EMS, and it could be used to send somebody home with hospice, for example, if their O2 requirements like less than 10 liters or something, less than 40. Non-invasive positive pressure ventilation, NIPPV, is a basket term used to refer to CPAP or BiPAP. Everyone knows CPAP from sleep apnea, and people can use it at home. People can use BiPAP at home too, but let's just go through each one. CPAP is a continuous amount of positive pressure, and it also has oxygen flowing through the tube as well. That oxygen can be titrated all the way up to 100% if you needed to. The nice thing about CPAP, if you're using it for somebody with pulmonary edema, somebody who's just got some sort of acute process and feels short of breath, is that it gives you some PEEP. And it generally offers some comfort for people that have some, dyspnea in that context. Let's see here. BiPAP is 2 levels of pressure. It's going to have an inspiratory pressure that sort of shoots air in, and it's going to have a stable expiratory pressure that sort of stints the airway open after the inspiratory breath. So if you're at bedside, the actual machine looks the same. It's going to look just like that. How you tell the difference is if you look at the machine, if it's showing you the pressure, if it's a CPAP, it'll be, let's say, 8 millimeters of mercury, and it's just flat. It's not changing. If it's a BiPAP, you'll see it shoot up, and you'll see it come back down to here. Shoot up, come back down to here. And that's the pressure number showing you that it's shooting air in and then holding at this pressure, shooting air in, holding at this pressure. Additionally, it's pretty obvious if you know how to recognize BiPAP, because at bedside, you'll hear whoosh, whoosh, whoosh. You'll hear the air being forced into the mask onto the patient's face. So in that sense, if you know what that sounds like, then you can recognize who's on BiPAP as opposed to CPAP. But again, BiPAP is nice because it is something that allows us to treat a lot of people with COPD who are developing acidosis. It can alleviate respiratory distress sometimes if done quickly. It can help to prevent intubation in some patients, and it generally helps to correct acidosis by helping you exchange air and maneuver the thorax to some extent. So it's a nice form of support that has really hopefully changed the game as far as not having to do a breathing tube for every COPD patient who gets a little bit acidotic. So BiPAP is nice, and people use BiPAP a lot just for respiratory distress in the ER, for example. And if someone is struggling to breathe, CPAP or BiPAP are both a good option. Often your RT will have an opinion about what they would like to try with the patient, and unless the patient has acidosis, I'm often willing to let the RT play a role in deciding what we use. So more about NIPPV, CPAP at night for OSA, you can do that in the floor, OBS units, ICU, whatever. If someone's on CPAP at home and they want their mask, order it for them. And then generally, sure, acute respiratory issues, you can use these forms of support. It has to be in an ICU or in the step-down unit. Can't do these on the floor unless it's somebody who's using it for sleep at night with CPAP. And then again, can't eat, can't drink, so it's a form of oxygen support that is somewhat critical if you need it during the day, because it's not a lasting solution. It's something that if you need it for a few hours to get by while we're doing something else to make you better, then all fair and good. If you're needing it day after day after day, then that's a situation where you have to wonder if that's someone who maybe needed to be intubated or needs to be intubated. Contraindications to BiPAP and CPAP are critical for you to know. You must know that right now, because you have the power to order these things and it will be put on people. Not everyone sits around and reconciles these contraindications every day, so now we're going to do it. So if your patient is unresponsive, obtunded, unarousable, if your patient is so sleepy they can't wake up, look at you, and give you a thumbs up and follow commands, they're not appropriate to be BiPAP'd in the step-down unit. Maybe in the ICU, but that would be attending and team-to-team dependent. If you go to somebody who's hypoxic and you hear this, this rattling sound that sounds like wet secretions that are stuck in the airway, that rattling is a sign that they're actively aspirating, either on something they ate recently or on their own secretions or on their own mucus. At any rate, that's somebody who, if you put a BiPAP mask on, you're going to blow that stuff deeper down into their airway and potentially cause mucus plugging and possibly worsen active aspiration. So that's somebody who needs to be intubated. Same with the obtunded, unresponsive, comatose patient, for example. If your patient is actively vomiting or is nauseous and you're concerned they may vomit, you probably should try to avoid putting them on CPAP or BiPAP. You should also be aware that it's possible with these modes of support that you could dilate the stomach and trigger nausea and vomiting. So That's something to be aware of. And that is another reason why your patient must be able to use their arms. They must be able to remove the mask. If your patient is paraplegic, if your patient is restrained and you can't unrestrain them, and if they can't follow commands to avoid either pulling that mask off inappropriately, or if they can't pull it off because guess what, they're getting sick, then that's a problem. This is why these are contraindications. Often the decision as far as if you're going to use BiPAP or if you're going to need to try high flow nasal cannula for somebody who's getting sicker is driven by your blood gas. And if somebody is developing acidosis, then you're going to need ventilatory support in the form of either BiPAP or intubation. And often you're trying to avoid sending people to the ventilator, and that's where BiPAP can be helpful. But if somebody doesn't have hypercarbia / if their pH is normal and you have just an oxygen issue, then go nuts. You can use the masks, you can use CPAP, and you can use high flow. And often I'd be working with the RT and working with the patient at bedside, trying to determine what they're going to be comfortable with and what's going to get their O2 saturations greater than 90%. Mechanical ventilation is really just not something I want to dig too deep on here. I don't think anyone should be looking at vent settings and crazy things like that at this stage of the game. But just be aware that if somebody has acidosis and they're not safe to BiPAP due to a contraindication, they got to be intubated. Somebody who's in respiratory distress, who isn't immediately getting better with another form of support, probably needs to be intubated. Hypoxia, despite maximizing CPAP, BiPAP, or high flow, intubated. And then a whole host of other reasons you might intubate somebody in the ICU that we won't talk about here. Okay, anybody who is getting sicker, whose O2 requirement is going up on high flow, or who's on BiPAP for a prolonged period of time and still short of breath or not comfortable or not showing signs that they're starting to turn the corner, in any one of those circumstances, it is probably reasonable to at least discuss an ICU consult, if not indicated to call the ICU.